Welcome. My name is Rebekka Thorud. I'm a senior resident at the Christus Health Texas A&M Emergency Medicine Residency in Corpus Christi, Texas. The title of my study is Patient Satisfaction with Subdissociative Dose Ketamine versus Morphine for the Emergency Department Treatment of Abdominal Pain. I'd like to recognize my co-authors, the doctors Youngblood, Shu, Torres, and Richmond. I have no financial conflicts or disclosures. By way of introduction, in the 1990s, regulatory agencies placed an increasing focus on the epidemic of untreated pain in the hospital. The Joint Commission adopted a slogan to encourage pain as the fifth vital sign. They encouraged prioritizing the treatment of pain. Opioid prescription rates increased dramatically over recent decades, with a rise from 76 million in 1991 to 219 million in 2011. As opioid overdose deaths became the #1 cause of accidental death in the US, researchers have turned their focus on the need to find alternative means to treat pain. In recent years, hospitals have begun to use patient satisfaction ratings as the metric by which they gauge healthcare outcomes and physician performance. The Affordable Care Act, Centers for Medicare and Medicaid Services, and the Institute of Health Improvement all have mandates that strive to improve the patient experience, health of the population, and reduce the per capita cost of healthcare. Hospitals that implement these measures are rewarded with higher Medicare reimbursement rates. All of this has led to a greater interest in non-opioid analgesic for pain control. Investigators have previously provided evidence that ketamine improved ED pain scores. Carlo et al. Demonstrated ketamine was safe and effective at low doses in treating pain. Sin et al. Found when ketamine was administered as an adjunct to morphine, the patient had better pain control and required less opioids overall. Poormond et al. Found that low-dose ketamine effectively treated pain while having an acceptable adverse effect profile. There is limited previous data regarding patient satisfaction following treatment with ketamine for analgesia. The objective of our study was to test the null hypothesis that there would be no difference in patient satisfaction scores for patients treated for abdominal pain with ketamine versus morphine. In terms of methods, this was a single-blinded, randomized control trial conducted at an urban emergency department. We enrolled a convenient sample of consenting adult ED patients ages 18 years or older who had a chief complaint of abdominal pain and a 10-point VAS pain rating greater than 5. Informed consent was obtained from patients presenting with a chief complaint of moderate to severe abdominal pain in the emergency department who did not meet any exclusion criteria. The patients were randomized into 2 groups. The study group received ketamine 0.3 milligrams per kilogram IV. The control group received 4 milligrams IV of morphine. Both medications were pushed over 3 to 5 minutes. Due to nursing regulation regarding the administration of ketamine, each drug was administered by a physician to ensure patient blinding. Patients were reassessed at 30 minutes post-treatment and given a survey to ascertain their VAS pain score and satisfaction on both a 5-point Likert scale as well as a VAS scale. For our statistical methods, the categorical data was analyzed by chi-square. The continuous data was analyzed by t-tests. Linear and multivariate regressions were performed to control for confounding. The study required 16 subjects in each group to have an 80% power to detect a 2.5 VAS satisfaction difference. The primary outcome parameter was to compare satisfaction scores between patients treated with morphine versus ketamine, respectively. With respect to our results, 32 patients were enrolled in this study. 16 of them received ketamine. Patients were similar for the following characteristics. 69% were female. The mean age was 46 years old in the morphine group and 39 years old in the ketamine. Mean BMI was 31 and 30 respectively. Pre-treatment pain score was 8.3 for the morphine group and 8.2 for the ketamine. Race was similar between both groups, with 75% of study participants being Hispanic. Patients who received morphine were more likely to require rescue medication, 56% in the morphine group and 19% in the ketamine group. Patients who received morphine had less reduction from their initial pain score, an average of 2.9 points in the morphine group and 5.1 points in the ketamine group. There was no difference between the two groups in Likert satisfaction ratings of 5 and VAS scores. We found within a linear regression model that ketamine was associated with larger pain score reductions, but the VAS satisfaction was similar for both groups. Within a multivariate regression model, Likert scores were similar between the two groups as well. By way of discussion, investigators have previously illustrated that ketamine has excellent efficacy as an analgesic in the emergency department. Sin et al. Demonstrated that ketamine can be used as an adjunct to morphine. Patients who received ketamine as an adjunct had a higher mean satisfaction score with their pain management with no serious adverse events. Carlo et al. Demonstrated that ketamine was safe and effective at low doses in treating pain. Ketamine was deemed non-inferior to morphine. There was a higher rate of non-severe adverse reactions with ketamine. Balzar et al. Demonstrated that low-dose ketamine and morphine had similar analgesic effectiveness within 60 minutes of administration with comparable safety profiles. In a study performed by Duncan et al., non-opioid pain alternatives for pain management can decrease opioid usage while maintaining patient satisfaction. The investigators utilized multimodal pain control. Multimodal was defined as any non-opioid intervention such as Tylenol, Motrin, IV fluids, oxygen, etc. This decreased opioid use by greater than 20%. There is a paucity of research to examine whether ketamine can be used for pain control without adversely influencing satisfaction. Our study compared ketamine at 0.3 milligrams per kilogram versus morphine at 4 milligrams. Other studies have used weight-based morphine at 0.1 milligrams per kilogram. We chose to use 4 milligrams of morphine as this is more reflective of true ED physician prescribing practices. In our study, ketamine was effective in reducing patients' pain. There was no difference in patient satisfaction with morphine versus ketamine. This was similar to Duncan et al. Study, which showed multimodal analgesia produced similar satisfaction scores as opioids alone. Limitations of our study were our small sample size. Larger studies are needed to confirm our findings. Our study population was predominantly Hispanic and lower income. Our results may not be generalizable to other populations. Also, we only evaluated patients with abdominal pain. In conclusion, patients treated with ketamine had larger reduction in their pain scores and required rescue pain medications less frequently than those treated with morphine. The concern with utilizing ketamine is that it will negatively impact patient satisfaction scores due to the adverse effect profile. However, in our study, patient satisfaction was similar in both treatment groups. Thank you.